Assalamu alaikum. This is Dr. Mariam Adult. I'm a professor in orthodontics and a senior orthodontic consultant. This lecture is going to be about interdisciplinary treatment, principle of orthodontic, restorative, and periodontal treatment. Sometimes if you read it in different chapters, actually it's adult orthodontics. The chapter is called adult orthodontics, because mainly perio considerations, restorative considerations are usually concerned with this category of our patients. So our reference mainly is chapter 20 from An Introduction to Orthodontics, 5th edition, Littlewoods and Mitchell. And as an extra reading, you can read chapter 19, Contemporary Orthodontics by Prophet, 6th edition. We're going to talk about comprehensive versus adjunctive versus limited treatment. We're going to talk about specific challenges in adult orthodontic treatment compared to children and adolescents, orthodontic and periodontal disease, special considerations, orthodontic as an adjunct to restorative work, with lots of clinical cases to show you this concept. Adult orthodontic patient, nowadays, the category of these patients is increasing in number, because the demand for treatment for this category has increased due to the awareness of the patient for aesthetic appearance and increased social acceptance of orthodontic appliance. Adult patients request a treatment for many reasons, just like the adolescents, okay? So usually to achieve better dental and smile aesthetics, and this represents the majority of our patients in general and adults in specific. Maybe it is to improve function, especially if we have mandibular displacement, cross bites, or maybe a patient had already orthodontic treatment. Like this patient, for example, she had extracted 4 premolars due to previous orthodontic treatment, and now there is reopening of spaces due to relapse, or maybe the previous orthodontic treatment was not successful, and now they seek orthodontic treatment to close spaces. Or it could be as an adjunct to other dental treatments. For example, this is an upper left 6 over-erupted into the space of the extracted lower left 6 surface. So if I want to replace this tooth, is difficult without going through orthodontic tooth movement and intrusion. And finally, to allow correction of jaw discrepancy, what we call orthodontic surgery. So this is an example of a patient who presented with a class 3 malocclusion with retrographic maxilla, increased vertical proportions, complicated by a crossbite affecting all teeth except for the upper right 6 and 7, open bite, and severe reversed overjet. So this is an example of a case that has a problem 3 dimensions. You can actually see also the facial asymmetry and the asymmetry intraorally as well. So we have anterior posteriorly there is a problem, vertically there is a problem, transversely there is a problem, and this is a patient who needs to be prepared for orthodontic surgery to be able to correct such malocclusion. It's very important before you start any treatment to know exactly where your patient fits in terms of the type of treatment. Is it going to be comprehensive or just an adjunct or limited treatment? Comprehensive, that means it's a total treatment of all features of the malocclusion, okay? You treat the whole malocclusion. And it's similar, if this is the case, usually the approach for treatment, choice of appliance, techniques, usually similar to that for children and adolescents, with the specific challenges that should be considered. Sometimes the treatment is only to facilitate other dental treatments. not to treat the malocclusion, but to facilitate other dental treatments like implants, restorations, crowns, etc. Or sometimes the all features of the malocclusion cannot be treated. You should accept few features and treat others, and usually these that you choose to treat are related to aesthetics. Adjunctive orthodontic treatment, by definition, is tooth movement carried out to facilitate other dental procedures necessary to control disease, restore function, and/or enhance appearance. Now, the approach to diagnosis and treatment planning for such patients could be interdisciplinary or it could be multidisciplinary. Interdisciplinary means that there is the effective utilization of the expertise and skills in the various disciplines of dentistry to improve the overall treatment prognosis and enhance treatment results. So it's an interactive procedure. What happens is that you gather all the records, you contact your colleagues, you assign a joint clinic, you call the patient, and you all sit together and you exchange opinions in order to reach to the ideal treatment for that patient. So this is an interactive process. It is interdisciplinary. Multidisciplinary, almost the same, but it's like an independent process where each specialty takes over a certain part of the treatment and then send the patient to the next specialty and so on. Actually, nowadays, it's mainly interdisciplinary therapy that is more common because of the ease of exchanging records. Nowadays, most of the records are digital, and it's easier to exchange records and have an online maybe chat and consultation before you actually sit together and see the patient. So it's easier to go with interdisciplinary. It's less common to have a multidisciplinary therapy for patients. If a patient is presented with multiple dental problems, it's important to prioritize which problem to treat first. We should always start by controlling active disease. For example, active caries should be controlled and have some restorations. Endo treatment should be done first, for example, if accessible. Periodontal disease should be put in under control and it should be treated, okay? I'm not talking about fancy restorations and crowns and bridges, etc. No, we're talking about preliminary restorations, something to withstand orthodontic treatment if necessary, and after that we think about the final restorations. So the first thing is disease control. After that, if necessary, we need to establish the occlusion with orthodontic treatment plus minus orthodontic surgery, okay? And after that, we go for definitive periodontal treatment and procedures, for example, osseous surgery, genioplasty, etc. And finally, definitive restorative treatment. So this is the priority of treating problems with a patient who presented with multiple dental problems. Now let's talk about our adult patient and how is this patient different from children and adolescents. There are a number of challenges that we could be faced with. Lack of growth, periodontal disease, missing or heavily restored teeth, physiologic factors that will affect tooth movement, motivation for treatment, previous orthodontic treatment, request for more aesthetic appliances. We will talk about each challenge and explain more about it. Now, lack of growth is an important factor. For example, this patient is presented with a class 2 division 1 malocclusion complicated by slightly retrognatic mandible, proclined upper incisors, multiple missing teeth, and restorative works, etc., with an overjet of 10 millimeters. So this is the main feature. So we cannot offer the patient, for example, functional appliance to treat the retrognatic mandible, okay, because the patient is an adult. So this option is out of the list. For example, headgear to restrain maxillary growth cannot be provided for adult patients. Chin cup, face mask cannot be provided for these patients. So growth modification is not possible. So if the patient is presented with a skeletal discrepancy, we have two options only, either to accept and camouflage or to go through orthodontic surgery to correct. Lack of growth also gives a challenge in terms of overbite reduction. If the overbite is deep, in children, it's a little bit easy. You just use flat anterior bite plane with a removable appliance and you separate the posterior teeth. What happens is that the posterior teeth will over-erupt, and then because the patient is still growing, the growth will accommodate the change in the vertical position of the molars. This is not possible with adults, so we cannot use flat anterior bite plane. Correction of overbite should not be attempted by extrusion of posterior segment because this will be relapsed. This is not stable. So what the alternative is to go through intrusion of the anterior segment. Rapid palatal expansion is another example of an appliance that we cannot use because it relies on the suture, mid-palatal suture that usually in children, it's feasible to go through a proper expansion, what we call skeletal expansion. But in adults, this suture is fused, and if we want to expand, usually we go through a procedure called surgically assisted expansion. So we open the suture, then we use rapid palatal expansion for a gradual opening of the suture and enhancement of bone formation. Right, periodontal disease is another challenge. Usually adult patients, more than children and adolescents, have suffered or are suffering periodontal problems. Any active periodontal disease should be treated first because we said disease should be brought under control. This is our priority. And then if orthodontic treatment is needed, then this should be done after, okay? The reduced periodontium resulted from previous periodontal problem per se is not a contraindication to orthodontic treatment. There are certain challenges carried out by reduced periodontium, but this is not a contraindication. What's a contraindication is an active periodontal disease. We cannot go through orthodontic treatment with an active orthodontic disease. What happens if we have reduced periodontal support? This is a healthy tooth, and this one here is a tooth with a reduced periodontal support, alveolar bone and periodontal support. What happens is that the amount of root embedded in bone is reduced. So the center of resistance will move more apically, right? So what happens is that we will have more excessive tipping if we apply the same force on both teeth. This one will have controlled tipping and this one will have more excessive uncontrolled tipping, okay? Now, the root surface area embedded in bone will reduce. So the same force will produce more pressure because the surface area here is reduced. So the pressure will increase. And this means the same force will be considered for this tooth ideal, but the same force for this tooth will be considered a heavy force with heavy pressure. So it's important to take this into consideration for patients with reduced periodontal support. The other thing is, if you remember, anchorage, which is the resistance to unwanted tooth movement, is very much dependent on the amount of root surface area embedded in the alveolar bone. Less root surface area embedded in the bone, that means anchorage control should be reassessed and is usually compromised in such cases. Now, if the center of resistance moved apically, what happens is that the arm for the moment will increase. And we know that the moment is produced from multiplication of the force applied multiplied by the D, which is the distance between where we apply, the point where we apply the force and the center of resistance. The arm, the D, for this patient here is shorter than the arm and the D for this patient with a reduced periodontal support. So what happens is that the moment, same force here will give a moment, but for this patient, the moment will increase. Okay, so this is why it's important to use lighter forces for patients with reduced periodontal support. not a contraindication, but we need to make certain modification to our techniques and amount of force that is used to move teeth. Another challenge for adult patients is missing or heavily restored teeth. Usually missing teeth will cause the surrounding teeth to start to move toward the empty area. They will tip, they will rotate, they will roll, and sometimes over-erupt. As you can see here, over-eruption, less on the left side, but very much severe on the right side. All these will complicate the occlusion, will complicate the treatment, and it will make it even more difficult to go for immediately for restorations. Now, heavily restored teeth also will affect the decision for extraction. So, for example, this patient here, if the patient presented with a class 2 division 1 malocclusion, and ideally I would go for extraction of 4s. In this dentition, it's impossible to go directly for extraction of 4s if you have other teeth endo-treated, badly destructed, heavily restored. So you cannot go with your conventional ideal extraction pattern. You have to modify it in order to take into consideration the tooth quality for these patients. Bonding appliance to different restorations is sometimes difficult and complicated. It's not like straightforward as we bond to the enamel. So if there are gold, amalgam, porcelain, zirconium restorations, you have to take certain techniques to bond your brackets on such surfaces. And if possible, you use bond instead of bands. You know, if you have a molar that you want to include into your treatment, it's better to use a tube. You bond the tube instead of having a band, if possible. And also, patients should be warned that sometimes when we finish our treatment or during treatment, we might damage the restorations that is already there, especially at the stage of debonding the fixed appliance. Definitive restoration should be postponed till the end of orthodontic treatment. Okay, so we only have a simple composite, amalgam, etc. But if there are crowns, bridges, this should be postponed until the end of orthodontic treatment. Another challenge are physiological factors affecting tooth movement. Adults will have reduced tissue blood supply and decreased cell turnover. So we will have slower initial tooth movement, only initial tooth movement, and more painful stage, the first few stages of treatment. But afterwards, children and adults will have the same rate of tooth movement. Only initial tooth movement will be slower in adults. In addition, of course, we need to use lighter forces as we explained compared to children, especially patients with reduced periodontal support. In terms of motivation for treatment, it's extremely important to understand exactly why the patient, the adult patient, is seeking treatment. Why now? What are their expectations? Okay. Luckily, most of adult patients are excellent, well-motivated patients, but sometimes we can have patients with body dysmorphic disorders, and they represent about 7.5% of our adult orthodontic patients. 7.5 is much more than those that are presented in the general population. In the general population, these represent about 0.7 to 3% with the body dysmorphic disorder. But in adult orthodontic patients, it's higher. And what's important about these patients is that they will never be satisfied with your treatment results. They will never be satisfied. Even if you reach excellent occlusion, they will always be moaning, and they will always have a problem with their occlusion, in their opinion, of course. But what's good about adult patients is that they usually understand why you're doing this treatment, so their cooperation will compensate for the slower initial tooth movement. So overall, there is no difference in treatment time comparing children with adults having the same malocclusion. Okay, it's important to educate the patient to set realistic expectations as it's difficult to satisfy patients who have unrealistic high expectations of the outcome of the treatment. Another challenge are patients with previous orthodontic treatment. It's important to take full history. What was the type of treatment the patient had? When did they have it? How long did it last? What was the type of appliance they had? Why was it unsuccessful? Why did the patient terminate the treatment? Why was there relapse? Why are they seeking treatment now? This is very important because this will tell you exactly what type of patients you're going to be starting with. Another thing is sometimes patients who had an excessive previous orthodontic treatment usually will have root resorption, and maybe starting another stage of fixed orthodontic treatment is not recommended. And the patient should be warned about further reduction in root length if the patient went through another fixed orthodontic treatment. Okay, so it's important to have a proper communication with the patients to understand this issue. Usually adult patients, because they know about the technologies and the progress in orthodontic appliances, usually they request more aesthetic orthodontic appliances. Now, lingual orthodontic appliances is an option, and it's the best one because the appliance is hidden in the lingual surface. Clear plastic aligners is another option. Labial ceramic brackets. And finally, the worst in terms of aesthetic is the metal labial appliances. Nevertheless, patients actually are now more accepting the orthodontic appliances than before. But of course, if we come to headgear, they are more reluctant to wear such an appliance, and therefore mini screws and temporary anchorage devices should be an alternative if anchorage is necessary. So these are the challenges that we could be faced with if we treat adult patients. Now we're going to come to more details about orthodontics and periodontal disease. Periodontal considerations is increasingly important for any patient, but mainly patients who becomes older. Full periodontal examination for all adult patients is a must, with bite wings for all posterior teeth and periapicals for all anterior teeth, as the guidelines stated in the United States of America. This is different in other countries, but this is what the guidelines are in the States. Basically, 6 points of probing for each tooth, full basic periodontal examination is a must for these patients. There is no contraindication, as we said, to treat patients who have had periodontal disease and bone loss. Okay, not are having periodontal disease. Any active periodontal disease, we should not start any orthodontic treatment. Even if the previous history of periodontal disease caused bone loss, of periodontal support, that's fine, as long as the disease has been brought under control. Teeth with reduced periodontal support can be safely moved, provided there is adequate plaque control and absence of inflammation, and as long as the orthodontist understands that lower forces should be used as the root surface area embedded in bone is reduced. The presence of plaque is the most important factor in initiation, progression, and recurrence of periodontal disease. So during visits, any presence of plaque, the patient should always be referred to the periodontist. Resistance bleeding on probing is the best indicator of active and progressive periodontal disease. Now, what happens if the patient is having an active periodontal disease is what we call pathologic tooth migration, malalignment problems, okay? Why? Well, because the teeth are sitting in normal conditions, they're sitting in the balancing zone, in between the tongue from inside, trying to push the teeth outside, and from outside we have the lips and the cheeks that are trying to push the teeth inside. What's actively balancing all these forces is the healthy periodontium, So if the periodontium was compromised, then the balancing zone will be disturbed, and we will have the tongue, which is stronger than the lips and the cheeks, will start to push the teeth outward. So the commonest presentation of such problem is brook-lined incisors. And this will even get worse if we have lack of some posterior support. Some posterior teeth are missing. What happens is that we will have more pressure on the labial segment and more brooklination. So this patient presented to our clinic saying that she never had her anterior teeth with such brooklination, such an overjet. What happens is that the patient had previous periodontal problems, now brought under control, but the balancing zone is already disturbed. As we said, center of resistance will move more apically. So the same conventional forces for a normal tooth, if used for a tooth with reduced periodontal support, will be considered heavy and inappropriate and will lead to uncontrolled and excessive tipping. So lighter forces are required. Ideally, for such patients, it's better to bone than band if possible. And of course, reduce retention of plaque by removing excess of adhesive. Any excess of adhesive should be removed so that we can make it easier for the patient to maintain excellent oral hygiene. Clear aligners, if possible, are better alternatives than the conventional brackets. Having plaque triangles is sometimes common for adult patients. These are the plaque triangles and they result from gingival recession and reduced periodontal support. So this is common. They could present actually before orthodontic treatment or during or after. So it's important for the patient to know that this is expected. Sometimes we can treat such problems by reducing interproximal reduction and moving the teeth toward each other. So the contact point will move further gingivally, and the soft tissue will be squeezed and fill part of this plaque triangle, or fully. They can fully fill the plaque triangles and treat it. So this is an option for treatments for such patients. At the end of the treatment, the patient will still be suffering reduced periodontal support if this is where we started. So the balancing zone will always be disturbed. So a relapse is highly possible for these patients. It's important to go for a more definitive retention and bonded retainer if possible. Now, orthodontic treatment is an adjunct to restorative work. To remind you, adjunctive means tooth movement carried out to facilitate other dental procedures. Okay, and usually we use this for patients with multiple dental problems. And usually this will need interdisciplinary treatment, more than one specialty to carry out the treatment. So a joint clinic is an excellent idea where different specialties will come together with the patient and with the proper records, and they will discuss the case and come out with a coordinated and appropriate treatment plan for that patient. So just to remind you, a patient with multiple dental problems, we should have comprehensive records, analyzing the records, and then we sit together and we come out with a proper treatment plan. We always start by controlling the disease, we reevaluate, and then we establish the occlusion, as we said, by orthodontic treatment and or orthodontic surgery, and then we move to definitive periorestorative treatment and maintenance of the periodontal health condition and restorations, of course. As we said, it's important to set realistic expectations for the patient. Sometimes the patient will come looking like this, suffering a bit of microdontia, spacing, missing lower permanent central incisors with retained A's. And what they think, what they imagine is that if they have only orthodontic treatment, this is where they end up. A full dentition, beautiful teeth, somehow they are bigger. So it's important, if this is what the patient is expecting, is just to educate the patient into a more realistic results and expectations. So we need to inform the patient that in orthodontics, we only move teeth. We don't change their shape. We don't grow teeth. We don't change their color. So, and in order to have a proper communication, it's good to have Kisling setup or digital setup. Doesn't have to be a wax and stone, etc. We can have a digital setup, and we can sit with the patient and explain exactly what's going to happen to their teeth after the treatment, and then the patient can help us to have the proper treatment plan that fulfill his expectations. Now, the main aims to facilitate for adjunctive orthodontic treatment is to facilitate restorative work by appropriate positioning of teeth, improve periodontal health by reducing areas that harbor plaque, position the teeth so that occlusal forces are transmitted along the long axis of teeth and tooth wear is more evenly distributed throughout the arch. So this is an example of a patient with severe crowding in the lower labial segment, and we have huge areas that favors harboring of plaque. So orthodontic treatment to relieve crowding can actually help this patient to maintain better oral hygiene. Severe class 2 division 2 malocclusion with severely retroclined upper and lower incisors, where treatment can actually enhance the transmitting of occlusal forces along the long axis of the tooth. And finally, facilitate restorative treatment by positioning the teeth so that more ideal and conservative techniques, including implants, can be used. Optimal aesthetics can be obtained with bonding, laminates, or full coverage porcelain restorations. So we're going to focus on the last goal, which is restorative work. We're going to give you only 4 examples on how orthodontic treatment can actually facilitate restorative work. The first example is uprighting of abutment teeth, redistribution or closure of spaces, intrusion of over-erupted teeth, extrusion of fractured teeth or a tooth with pathology. Uprighting of abutment teeth is necessary to facilitate usually implants or bridge or prosthetic replacement of a missing tooth. And this is an example of a missing lower left 6, where the 7 is tilted severely mesially. It should be uprighted, and then this is easier access for a prosthetic replacement. This is an example. Our patient presented with class 1 malocclusion complicated by multiple individual crossbites affecting both laterals and both second premolars. This case was complicated by an extracted upper left 4, and actually she wanted to have an implant in that area, and this is why she was referred to our department. So basically, the patient will need not only an adjunctive orthodontic treatment to open space and to provide root parallelism in order to enhance placement of an implant, but actually she will need a comprehensive orthodontic treatment. So the patient was offered Plan A, comprehensive orthodontic treatment, or just part of the area here to open space for a prosthetic replacement. And of course, the patient chose option A after proper communication with her, which was the ideal treatment for her. Now, the case was actually, after we took proper records, the case was complicated by a supernumerary in the lower left quadrant. So the treatment was adjusted, and we decided to use this supplementary tooth to replace the missing upper left 4. So fixed appliance was planned to correct the crossbites, align and level open space for the missing upper left 4. And in the lower arch, we could not fit any appliance because we did not want to compromise the roots adjacent to the supplementary tooth in the lower left quadrant. So we had to postpone this until we auto-transplant the supernumerary into the upper arch. So now we're happy with the root parallelism between the 5 and the 3. We send the patient for the surgical department. The tooth will, by the time the patient was referred for surgery, actually the lower supplementary premolar had already erupted, which was good in terms of a less traumatic extraction procedure. So the tooth was extracted and immediately implanted into the area we provided. And this is after it was auto-transplanted. And now we can move to lower fixed appliance safely to align the teeth. And now the patient is ready for any further restorations in order to improve the shape of such a tooth. Redistribution or closure of spaces. Usually spacing is there due to hypodontia or extracted teeth, or a tooth was lost due to trauma, or sometimes teeth are small, big-shaped laterals, microdontia that is generalized or localized, or due to pathologic migration of teeth that we talked about that resulted from periodontal disease and reduced periodontal support for the teeth. So all these factors can contribute to presence of spaces. So we have to decide, do we need to close the spaces, or do we need to open the spaces for prosthetic replacements, or just redistribute spaces? So this is an example of a case that was referred to our clinic. The patient had 2 missing premolars in the upper left quadrant, 4 and 5, but the space was not small enough for 1 implant and was not big enough for 2 implants. So the patient was referred only to increase the space from 12 millimeters to 15 millimeters. And this is exactly what we're trying to do, taking into consideration the diastema and the possibility to propline a little bit the incisors in order to get these extra 3 millimeters. Another example of a space redistribution is this patient. This patient is presented with a class 1 malocclusion, complicated by missing upper left lateral incisor. The upper right lateral incisor is suffering microdontia, small, and both upper sixes were badly destructed. And as you can see on the OPG, we have remaining roots. Okay, so this patient will need a comprehensive orthodontic treatment, and part of the treatment is to open space for the upper left lateral incisor to replace it with an implant, and the upper right lateral incisor we need to open spaces in order to increase its size with a restorative treatment. With regards to the spaces of the upper sixes, the decision was made to close the spaces. So this is the patient at the end of the treatment. If you look at the left side, you can hardly guess that the 6 was actually replaced by the 7, and this side here, because the wisdom was a little bit delayed in development, as you can see here, it will take some time for it to erupt in that position. So the patient is ready for an implant, and as you can see, spaces were opened around the lateral for restoration. Another also a very nice example of a patient who had a history of trauma, a fracture to crown of the upper left central incisor. The case was complicated with a crossbite and very mild crowding in the lower labial segment. So the decision was made to correct the crossbite, align and level, and open space for the central incisor in the upper left quadrant for a temporary replacement of the tooth, because the patient was 14 years old, still young. We cannot go for other permanent restorations or prosthetic replacements. We did not extract the remaining root. Why? Because we have a concept called banking of alveolar bone. If we extract the tooth, what happens is that we will have nicking of bone. And this is one of the problems related to missing teeth. Nicking of bone is the reduction in the alveolar bone buccolingual width and in the vertical dimension as well. And we will have more dense cortical bone that is more difficult for us to move teeth around. And it's more difficult for other specialties to fit prosthetic replacement like an implant. They will have less success rate, and they will need to have bone graft, soft tissue graft before the implants, which is even more difficult for the patient. So here we decided to keep the root, because if the root is there, then we will have bone surrounding it. And this is what we call banking of the alveolar bone. It's like we save the alveolar bone for later. Okay. So the patient went through a fixed orthodontic treatment in the upper and the lower. We corrected the crossbite. We distalized the canine into a class 1 canine relationship. And now we open the space that is symmetrical to the right side in order to replace this tooth temporarily with a prosthetic replacement. And later on, when the patient is old enough, then we can go for the definitive treatment. Usually when the patient is old enough, an alternative to immediate extraction of the root and an implant is what we call forced extraction. Forced extraction means that we gradually extrude the tooth with a rate of about less than 2 millimeters per month until we get rid of the whole remaining roots. It's like forced slow extraction. After we get rid of this piece of the root, we wait at least 1 month for the bone to remodel, regenerate, and then we can go for our definitive treatment. What's good about that is that as you extrude the remaining root slowly, the gingiva will follow and the bone will follow, and you will have better soft tissues and bone quality to have a better success rate for the implant. Now, the third scenario is intrusion of over-erupted teeth. Okay, usually intrusion is for posterior segment if we have the contra, the opposing tooth is missing, or for the anterior teeth if we need to reduce the overbite in adult patients. So this is a patient who has a class 3 malocclusion, a very mild crowding. The occlusion was very acceptable. She was only referred because the lower left 6 was extracted and they wanted to go for an implant, but the upper left 6 over-erupted. And you can see the huge step between the 7 and the 6. So here we don't need to go through comprehensive orthodontic treatment. We just needed to go through partial fixed appliance. I needed to think where I need to put my the tabs, the mini screws, the temporary anchorage device. And as you can see, the yellow area is a safe area for my mini screw. So I fitted the mini screw between the roots of the 5 and the 6 palatally and between the 5 and the 7 buccally. So this is the implant buccally between the 6 and the 7, and this is the implant palatally between the 5 and the 6. And I only needed partial fixed, not a full fixed appliance. And you can see the improvement in the step between the 6 and the 7. And now we're opening the spaces, and the patient is ready for an implant and restorative work in the lower arch. Another example of a patient that that is having the exact same scenario, but this case is complicated with a class 2 division 1 malocclusion, 10 millimeter overjet, increased maxillomandibular plane angle, increased vertical proportions, incompetent lips, retrognathic mandible, with crowding and remaining root of lower right and left first molars. Okay, so the patient refused orthodontic surgery, which was ideal for her case. So we had to go through a compromised treatment where we accept the skeletal pattern and we extracted upper 4s in order to reduce the overjet. Of course, part of our aims was to intrude the upper left first molar in order to make it possible for the to insert an implant in the lower left quadrant. So this is the patient after extraction. Now alignment level, we had masked to reinforce anchorage, and we wanted it to be away from the palate in order to enhance intrusion. This is the screw buccally and the glans palatally in order to control the position of the tooth. And you can actually see the huge step between the 6 and the 7 improving. And this is the patient near end of treatment with enough space to replace the missing lower left 6. Right. Extrusion of fractured teeth to bring the fracture line supragingivally to allow placement of a crown or restoration. Okay, but if you do this, it's important to take into consideration the crown root ratio. It should be minimum 1-to-1 ratio, minimum. Okay, otherwise it will be compromised and it will need to be splinted to the surrounding teeth. This is an example from Prophet. You can see a tooth here that is suffering pathology that is positioned subgingivally. And the plan was to extrude the tooth so that sound structures are exposed supragingivally. And then genioplasty and final restorations are planned for this patient. Another example, our patient Sarah, she suffered trauma to her upper central incisors. The upper right central incisor is, as you can see, has a fracture near the apical third here. The left one had a fracture, incomplete fracture that is positioned subgingivally. So the patient was referred only to extrude the upper left central incisor about 4 millimeters in order to expose sound tooth structures and carry out further necessary treatment and restorations for this case. So we designed only partial fixed appliance, not a comprehensive treatment, because she has acceptable occlusion, very mild crowding, acceptable occlusion. So we could not bond anything to the upper right because it was compromised and fractures. We only focused on the extrusion of the upper left central incisor. So as you can see, this is the progress of the treatment. And this is exactly the amount of extrusion that was requested. You can see that the right side is actually our reference because we did not move it. The tooth that we moved was the upper left central incisor, so if you can see the amount of extrusion. And now the patient is ready to be referred back for further restorative work. So this is the 4 scenarios where orthodontic tooth movement can be an adjunct to the restorative work. And this is just to remind you with our lecture outline. This is Dr. Mariam Adult, and thank you for listening.